Hello, welcome to the American Liver Foundation's Hepatitis Awareness Program, updates on hepatitis B and C virus for patients. Today is May 16th, 2024. My name is Ivory Allison, and I am the National Senior Director for Community Impact with the American Liver Foundation. We are so excited to welcome all of you today. I would like to welcome Dr. Emmanuel Thomas, the American Liver Foundation's Board Chair. Hello, Dr. Thomas.
Thank you, Ivory, for that kind introduction. I'd like to welcome everyone to our American Liver Foundation's updates on Hep B and C for patients. So, as was said, my name is Emmanuel Thomas. I'm an associate professor at the University of Miami School of Medicine in the Department of Pathology, and I'm also the American Liver Foundation board chair, and I'll be your moderator today. We have an exciting program today, and before we start, I just want to mention that the American Liver Foundation is the nation's largest nonprofit serving people with liver disease, where we provide a voice and an ear for people with liver disease and their families through education, support, research, and advocacy. ALF was actually founded 48 years ago, and it's the nation's largest patient advocacy organization for individuals with liver disease. Each year, we engage over 5 million people through our robust education, support, and awareness initiatives. As part of our commitment to the liver community, ALF offers a range of educational programs for patients. And I encourage all of you to visit your website if you haven't been on our website yet. So today, just for a brief background on Zoom etiquette, the program is being delivered on the Zoom webinar platform and will be recorded and will be available on ALF's YouTube channel for future viewing. During today's presentations, if you have a question or comment, please hover your mouse over the bottom of your screen and click on the Q&A feature. We will make every effort to ask all questions during the Q&A portion of the program. Importantly, our speakers will do their best to answer pertinent questions to their talk when they are not speaking to try to get to all of the questions. Today's speakers are Dr. Min Kim, MD, MPH, physician, Clinical Interventions Team, Division of Viral Hepatitis from the Centers for Disease Control and Prevention. Our second speaker will be Dr. Robert Wong, MD, Masters, Clinical Associate Professor, Department of Medicine, Division of Gastroenterology and Hepatology, Stanford University School of Medicine. And lastly, Dr. Nathan Furukawa, MD, MPH, Senior Advisor for Hepatitis C Elimination, Division of Viral Hepatitis, Centers for Disease Control and Prevention. With that, I'll turn it over to Dr. Min Kim to lead us off with the first presentation. Please share your slides when you can, Dr. Kim, and thank you so much for contributing to our program. We really appreciate it.
Thank you for the introduction. I'll go ahead and share the screen. Can you see my slide now?
Yes.
Okay. Good afternoon, everyone. Thank you for the opportunity to present today. My name is Min Kim, and I'm a physician and adult hepatitis B subject matter expert on the clinical intervention team of the Division of Viral Hepatitis at CDC. I will be providing an overview of CDC recommendations for hepatitis B screening and how it integrates with the ACIP vaccination recommendations. Today's objectives are as follows. Number one, provide an overview of the epidemiology of hepatitis B in the United States. Number two, describe the current adult CDC and Advisory Committee on Immunization Practices recommendations for hepatitis B screening and vaccination. Hepatitis B in the United States can be thought of as a tale of two epidemiologies. The largest proportion of people living with chronic hepatitis B were born outside of the US and have had the infection since childhood. Next slide. The other group disproportionately impacted are unvaccinated people with behavioral risk factors such as injection drug use or condomless sex who acquired the infection as adults. Next slide. On the left, during 2022, the rate of chronic hepatitis B was highest among persons aged 30 to 39 and 40 to 49 years and accounted for 47% of all chronic hepatitis B cases reported in 2022. On the right, the rate of chronic hepatitis B was highest among non-Hispanic Asian Pacific Islander persons and was over 11 times the rate among non-Hispanic white persons. Next slide, please. People with chronic hepatitis B virus infection are at increased risk for liver cancer and cirrhosis and are 70 to 85% more likely to die prematurely than the general population. Next slide, please. On the left, during 2022, a total of 1,797 hepatitis B-related deaths among U.S. residents were reported in the U.S. multiple cause of death data obtained from death certificates, which corresponds to an age-adjusted death rate of 0.44 cases per 100,000 population. But what I really want to highlight is the graph on the right, which you can see that in 2022, the hepatitis B-related mortality rate was highest among non-Hispanic Asian Pacific Islander persons and was 8.5 times the rate among non-Hispanic white persons. Despite the high mortality rate, hepatitis B virus infection is vaccine preventable. Next slide. Now, I will talk about CDC's latest hepatitis B screening and testing recommendations for adults. Next slide. Previously, hepatitis B screening followed a risk-based approach. However, limitations of a risk-based approach can be seen in our surveillance data. From data on new acute cases of hepatitis B reported to CDC, 2/3 of cases were either missing risk data or had no reported risk identified. Next slide. CDC's latest hepatitis B screening and testing recommendation for adults was published in March 2023. Central to the new recommendation is to screen all adults aged 18 years and older at least once in their lifetime, as well as anyone who requests screening, because we know people may be reluctant to tell their doctor about potentially stigmatizing risk behaviors. Screening is recommended using a 3-test panel that includes hepatitis B surface antigen, hepatitis B surface antibody, and total hepatitis B core antibody. What remains unchanged from prior recommendations is that screening is recommended for all pregnant persons during each pregnancy, preferably in the first trimester, regardless of vaccination status or history of testing. That testing is recommended for anyone with a history of risk behaviors, and that periodic testing is recommended for susceptible persons with ongoing risk behaviors. Next slide, please. The 2023 guideline expanded risk-based testing from the 2018 guideline to include the following populations, activities, exposure, or conditions associated with increased risk for hepatitis B virus infection. People currently or formerly incarcerated in a jail, prison, or other detention setting. People with a history of hepatitis C virus infection. People with a history of sexually transmitted infections or multiple sex partners. Next slide, please. CDC recommends using the triple panel testing, which comprises of hepatitis B surface antigen and antibody to hepatitis B surface antigen and total antibody to hepatitis core antigen. Next slide, please. The rationale behind recommending the 3 screening tests is that it allows for a more complete clinical picture. Shown here is a table of the combination of results with the associated clinical interpretation and action. Red means positive, blue means negative for the test result. The 3 tests can allow the provider to establish whether the patient has an acute or chronic infection, whether they had past resolved infection, if they show evidence of current immunity due to vaccination, whether they may be susceptible and should be vaccinated, or if they may need additional follow-up with the specialist to determine their status. Next slide, please. Now, I will describe the ACIP hepatitis B vaccination recommendations. Next slide. While infant and childhood vaccination has been a success, it is a different clinical picture for adults born before universal infant vaccination. Self-reported National Health Interview Survey data show that a large proportion of adults at higher risk remain unvaccinated, with rates of vaccination decreasing by age. This means a large proportion of population at higher risk remains vulnerable to hepatitis B vaccine infection. Next slide. The latest Hep B vaccination recommendation among adults was published in June 2022. Central to the recommendation is the following. All adults aged 19 through 59 years and adults aged 60 years and older with risk factors for hepatitis B should receive hepatitis B vaccination, and adults aged 60 years and older without known risk factors for hepatitis B may receive hepatitis B vaccination. Next slide, please. A little about the hepatitis B screening and vaccination sequence. After the collection of blood for triple panel screening, people who have not completed a vaccine series should be offered the vaccination per the ACIP recommendations at the same visit or associated provider visit. It is not necessary to wait for the screening results to administer the first vaccine dose. However, blood should be drawn before the vaccine is administered. While screening can identify unvaccinated people, it should not be a barrier to vaccination, especially in populations that have decreased engagement with or access to care. Next slide, please. And next slide. Now, we must do the work to take action on implementing hepatitis B screening, testing, and vaccination guidelines. Meaningful education that will take all of us will be needed to increase awareness and empower providers to feel comfortable ordering and interpreting the screening results. Patient education that is in shared language and from trusted sources will be needed to encourage uptake of screening and vaccination. Next slide, please. As we hope to expand the screening and vaccination to settings like pharmacies, primary care, or harm reduction programs, there is a need to develop setting-specific guides and best practices. Some such best practices learned from other diseases include electronic health record alerts. There will be no doubt some challenges in figuring out how to integrate screening and vaccination. However, we can learn lessons from COVID-19 and rapid adoption of new systems and practices. Next slide. Laboratories can assist in this effort by supporting the development of hepatitis B lab panels that include triple panel screening with a clear summary and interpretation of the result. Next slide. CMS could consider streamlining hepatitis B screening reimbursement by eliminating the requirement for providers to report hepatitis B screening with an additional ICD-10 diagnosis code for risk behaviors, which is a step that may be easily overlooked or that providers may be reluctant to enter. Next slide. Finally, there is future potential for U.S. Preventive Services Task Force alignment, which would be key to ensuring coverage by payers. These steps are high level and only just a start. CDC recognizes that partners are already hard at work planning implementation of these guidelines in different settings. We look forward to highlighting your best practices and sharing success stories. Next slide. This is an example from California Department of Public Health Immunization Branch on hepatitis B job aid. A job aid is a resource that helps someone doing the job, which in this case is for providers. This is available to the public on their website, and this information was presented at the recent 2024 viral hepatitis meeting in Atlanta, Georgia. Next slide. I would like to share some other resources from CDC and our partners, including the University of Washington, Hepatitis B Foundation, and immunize.org. They have great resources for providers and patients, including trainings and frequently asked questions. Next slide. In summary, universal screening for hepatitis B virus infection is recommended at least once in a lifetime for all adults 18 years and older. Hepatitis B vaccination is recommended for all adults aged 19 through 59 years and adults 60 years and older with risk factors. Adults 60 years and older without risk factors may receive vaccination. Support for co-located comprehensive access to hepatitis B services is needed for implementation of screening, testing, and vaccination recommendations. There are resources available. Finally, hepatitis B screening, testing, and vaccination can save lives. Thank you for your attention. We will take questions at the end. And here is my contact information.
Thank you, Dr. Kim. We appreciate that. We next are going to move to Dr. Robert Wong for the next presentation. And it was mentioned, we'll take questions at the end. Dr. Wong.
Well, thanks everyone for joining us. I'm going to be following on Dr. Kim's excellent talk on the approach to screening and vaccination updates. And my session will be focused on disparities in the hepatitis B cascade of care. So the objectives for the next 10 minutes or so will be a brief overview of Hep B, Epi, some of that you heard about earlier in the previous talk, and focus really on the chronic hepatitis B cascade of care, highlight existing gaps and disparities in the cascade of care, and why is that important, and how that contributes to disparities in downstream outcomes. So this is a sort of simplified diagram that I like to think about with any liver disease, but particularly with hepatitis B. And I think it highlights a few key important points. One, the complexity of hepatitis B. Two, the fact that it really starts with what Dr. Kim was emphasizing earlier is adequate implementation of screening programs. But as you can see here, screening is just the first step, and the downstream cascade of diagnosis, linkage to care, retention, and assessing eligibility for treatment, plugging into treatment are all critically important steps in the cascade of care with the goal of reducing downstream liver cancer, HCC, cirrhosis, and liver-related morbidity and mortality. The little bubbles that I highlight along the cascade illustrate some of the potential gaps and disparities and challenges and barriers that patients face with hepatitis B. And unfortunately, along each step of this cascade, these barriers and challenges can really contribute to people falling off this cascade, and hence the importance of really thinking about these different challenges and proactively addressing them as we see patients day to day in the clinic. Hep B, Epi, epidemiology. This is from a global standpoint, and then we'll come back down to the national US data. These are data from a few years ago that really characterized the global burden of hepatitis B, about 300 million individuals globally affected. But even more concerning, if you look at the subsequent bar graphs, what of the 300 or so million individuals with hepatitis B, you can see in the third bar, only a small fraction are diagnosed. So the vast majority of patients, at least globally, are unaware, undiagnosed. And even more concerning, if you look at the far right bar, a very, very small proportion of these individuals are actually receiving antiviral therapy. What about in the US? These are data we published a few years ago, and we estimated the prevalence of chronic hepatitis B in the US in 2022 is almost 2 million. And similar to the global data, many of these individuals are undiagnosed, and hence the importance of implementing, especially the new guidelines on universal screening and vaccination of those that are negative on screening, That's the only way that we're going to be able to identify these individuals early and plug them into appropriate care. What are some of the gaps and disparities that have been reported? Here I highlight 3 studies specifically looking at gaps in timely diagnosis. The first bullet point illustrates a large study across 17 states called the REACH cohorts. And these were studies of individuals of ethnic minority background. So these are individuals that should be tested for hepatitis B. In that study, you can see less than 40% were tested for hepatitis B. Another study in the Kaiser Permanente Hawaii system of predominantly Asian Pacific Islander communities found that 28% were tested. And then most recently, a paper published just a few years ago using US data, using the TRUVEN and the NHANES large database, and observed that of the 511,000 commercially insured adults with chronic hepatitis B, only 18% were diagnosed. That's very concerning because if you're not diagnosed, of course, you're not going to be plugged into appropriate hepatitis B care. Lack of awareness also contributes to suboptimal engagements. These are data from the NHANES study from 2013 to 2016, where the study looked at patients with hepatitis B to assess if people were aware. And very interesting that of people with documented lab-confirmed hepatitis B, less than a third were even aware of their infection. And amongst those that were aware, only 28% received treatment. So big gaps in awareness as well as linkage to care and treatments. And unfortunately, again and again, we see that certain individuals, vulnerable populations, especially those with lower socioeconomic status, education, were less likely to be aware and hence less likely to be treated for their hepatitis B. Understanding gaps are important because they can guide target interventions. In some ways, poor clinical outcomes are preventable, but you have to be able to identify what are the modifiable factors that can be addressed. Early detection and timely access to effective therapies is something we can improve. And that can be improved through a variety of ways: education, quality improvement programs, all of these done in conjunction with really implementing the screening and vaccination policies that were discussed earlier. As I mentioned, low socioeconomic status individuals and vulnerable populations are disproportionately experiencing healthcare disparities. And this is certainly the case in hepatitis B, compounding their existing inequities, whether it's insurance status, education, income, all of these factors compound together to exacerbate disparities, particularly in hepatitis B as well. What about linkage to care? This is a study, a single center study in a safety net hospital in the Bay Area of Northern California, where we looked at 454 patients with chronic hepatitis B, predominantly Asian hepatitis B patients. We looked at 2 factors. 1, linkage to care, meaning first visit after diagnosis of hepatitis B, and then retention. Linkage is important, but retaining people into care is equally important for hepatitis B. You can see here, only 63% were successfully linked to care. We saw some disparities by race, ethnicity, but one key point the far graphs on the right illustrate is having a primary care is critically important because it's a marker of engagement to care. Those that were linked, only 70% were retained. So another way of saying it, almost a third of people that were linked fell off to care and were not getting continued laboratory monitoring and assessment, which is an important gap in the hepatitis B cascade. Why is that important? That leads to progressive damage. This is a follow-up data from that study that show that at presentation, 28% of patients had already developed cirrhosis, and many of these patients had other cirrhosis-related complications. We saw some disparities with men more likely to present with cirrhosis and some differences by hepatitis B markers. But the key point is that early diagnosis, linkage to care, and treatment can potentially prevent some of these downstream complications that we're seeing in the clinic. What about access to treatment? Treatment is available, it's safe, effective, but not everyone is getting treated in a timely manner. This is a big multi-centered study that we did in 4 safety net hospitals in the US of over 5,000 patients with chronic hepatitis B. Using AASLD criteria, we identified that approximately 46.8% were eligible for treatment, but among those that were treatment eligible, less than half received hepatitis B therapy. So very important to think about not just monitoring, but when those individuals are eligible, it's really important to get them linked to timely antiviral therapy to reduce the long-term risk of complications. Why is that important? Well, we also looked, in addition to overall treatment, we looked at whether there are certain disparities, as we mentioned. We saw that, unfortunately, there were some stark disparities seen. Both the figures and the tables illustrated here in this slide show women were less likely to be treated than men. And this is all among people that are treatment eligible. We also saw some disparities by race, ethnicity, as well as by insurance status. So overall, it's important to think about ensuring these patients are plugged into treatments and also thinking about vulnerable populations who may be experiencing particularly stark disparities in access to care and treatment. I just wanted to highlight this. This is relatively hot off the press. These are new World Health Organization treatment guidelines. Treatment guidelines we can talk about in the Q&A session, but it's really complicated in the current state. But more and more, there is a movement to simplify treatment to make it easier for us to assess and get these patients linked to care. So these are some of the new recommendations that were proposed by World Health Organization, and I think it's a very progressive move towards simplifying and really improving access to care and treatment for hepatitis B, not just in the US, but globally. Why are disparities important? Because disparities in linkage to care lead to continued disease progression to cirrhosis and HCC, and hence delays and gaps in linkage, especially among these minority and underserved populations, really exacerbate liver disease burden and complications. These are just a few figures here from one study that show the impact of hepatitis B therapy on risk of liver cancer. In all the graphs, the dotted line shows patients that are not treated, and the solid line shows patients that are treated. So whether you look at the whole population or you stratify by patients with or without cirrhosis, it's very clear the antiviral therapy is very effective at reducing the risk of cancer, hence the importance of really engaging these patients and ensuring they get timely access to hepatitis B antiviral therapy. It sounds simple, but it's very complicated. And this is another way to think about the cascade that I showed earlier in the slide, that there are multiple barriers to effective viral hepatitis care. And many times all of these are at play, whether they're patient factors, provider factors, health system factors, and a lot of other players are important to think about: payers, advocacy groups, medical societies, public health departments, and it really takes a concerted, comprehensive effort in addressing all of these domains to effectively improve viral hepatitis care. All of these also are unique depending where you practice, the type of patient you see, the population you serve. So it's important to really think about this in a comprehensive manner and really tailor your approach to improve hepatitis care to your own community that you are practicing or serving. What are the take-home points? Hopefully, I've been able to convey that there are major gaps in the chronic hepatitis B cascade of care, and this really exacerbates disparities in patient outcomes. We heard about the new guidelines for universal screening as well as vaccination, and I think that that will definitely improve the early detection and linkage to care of many undiagnosed patients. But screening is just the first step. If we think back to the cascade I show, after screening and diagnosis, we must ensure that patients are timely linked to care and treatments And really the model to think about is screen, vaccinate, linkage to care, and ultimately treatment. Thank you so much.
Thank you, Dr. Wong, for that great presentation. And finally, we'll have Dr. Furukawa speak about hepatitis C elimination. Thank you, Dr. Furukawa. Stage is yours.
Thank you. Yeah, thanks for the opportunity again to speak with you about an update on hepatitis C elimination. I've entitled it Signs of Progress and Promise, but so much further to go. So with that, I'll get started. First, wanted to give you an overview, kind of where we stand from an epidemiologic standpoint in terms of elimination. So starting with some good news, hepatitis C related deaths have been steadily declining. Part of that is related to treatment. Another part may be related just to a generational cohort effect with that baby boomer population aging and passing away, and that generation X not having lower levels of hepatitis C infection. But on the other hand, if we look on the infection side of the equation, we see that unfortunately, as a consequence of the opioid and drug use crisis, rates of hepatitis C infection have actually been increasing. Although last year of data available, 2022, there was a sign of potential progress in that it may have plateaued. Regardless, we still are rather far away from our goal of eliminating or reducing new HCV-related infections by more than 90% by 2030. So to categorize that a little bit more, on the left, you can see a graph depicting the number of treatments for hepatitis C. And you can see when DAAs were first available, you see an initial spike in treatment, but then over time, it's actually trickled, with the most recent year shown 2020 showing a pretty notable decline compared to even the first year. And the graph on the right demonstrates the proportion of people who, upon diagnosis, are treated within 1 year for hepatitis C, stratified by payer type. And you can see across the board, it's pretty low. Even in the best scenario for people with commercial insurance, it's only 35% are treated within a year of diagnosis, and then much worse for Medicaid at 23%. So overall, despite more people being treated, there's still quite a bit of a gap there. And the result here is that overall, among people diagnosed with hepatitis C, only about 1 in 3 have evidence of viral clearance. And if you break it down by people without health insurance, people under the age of 40, or people both under the age of 40 without insurance, you see that proportion that are virally cleared is increasingly less. And if we look kind of at the big picture, prevalence-wise, from the 2013 to 2016 period, we estimated there were about 2.1 million people based on the NHANES survey with hepatitis C. Fast forward to 2017 to 2020, and unfortunately that number stayed about the same, with people increasingly being infected, but increasingly being treated, and that almost balancing itself out. So wanted to also give you some updates about guidelines that have been released within the past year. I first wanted just to reiterate the bigger guideline change from 2020, where CDC released guidelines recommending universal HCV screening among adults, screening for HCV during each pregnancy, and then, as before, interval testing for people with ongoing risk factors such as injection drug use. And new to 2023 was our updated perinatal HCV testing recommendations. So in here, we recommend, again, reiterating screening for hepatitis C during each pregnancy, testing all babies that are exposed during pregnancy, and this time with an RNA test between the ages of 2 to 6 months, and then managing infants who are HCV RNA positive alongside a provider with pediatric hepatitis C experience. Also new in 2023 was an update to the AASLD IDSA hepatitis C guidelines. The big updates since the last update in 2020 include a reemphasis on the just centrality of universal screening and treatment, but also an expansion of people who are eligible for simplified treatment. So before it was mostly people with non-decompensated cirrhosis, and this has been expanded to also include people living with HIV. Additionally, new to the updated guidelines include reducing the amount of on-treatment monitoring and really taking a minimal approach, which through prior clinical trials demonstrated equivalent outcomes. And then also an emphasis on universal opt-out testing and treatment in jails and prisons, places where people with hepatitis C cycle through frequently, and venues which one could augment the amount of people being tested and treated for this disease. And then next, I want to shift to really kind of what are the big new developments in the field of hepatitis C. And there's some exciting ones for sure this year. This is just to reiterate that there are a number of different barriers to people getting diagnosed and treated with hepatitis C. That can include people not being aware of viral hepatitis itself, people experiencing stigma and not presenting to healthcare for either testing and or treatment. Our current two-step diagnostic testing pathway, which requires an antibody followed by RNA testing. The price of the DAAs themselves are high. That can result in insurance coverage gaps or insurance treatment restrictions, and the fact that the treatment is not co-located in the place with hepatitis C, the places where people with hepatitis C often seek care. And in general, it can be people with hepatitis C may be difficult to reach populations in that they may have a lot of co-occurring substance use disorder, mental health challenges, housing instability that may interfere with their ability to prioritize hepatitis C testing and treatment. So with that in mind, CDC is really trying to push the field to increasingly decentralize and simplify testing and treatment and bring it to these priority high impact settings where we see it easy to, I shouldn't say easy, but possible to implement co-located testing and treatment. So that can include federally qualified health centers or community health centers, large jails and prisons, programs that offer medications for opioid use disorder, be that outpatient MAT clinics or opioid treatment programs, and then syringe service programs or SSPs. And there's been some really wonderful work in that regard, in that CDC has been working with the Independent Test Assessment Program, or ITAP, which was part of the larger RADx program out of NIH, that it has accelerated a lot of priority diagnostics to market. We had supported ITAP through their process of identifying a manufacturer mid last year, and actually starting independent laboratory testing, analytic studies, and prepping for clinical trials. This year, we'd launched clinical trials and actually have completed them. So anticipate that this summer, there will actually be a CLIA-Wave fingerstick point-of-care HCV RNA test available, which would drastically help us in further decentralizing hepatitis C testing and treatment. Relatedly, CDC looked back at our old guidelines to see if we could clear the way and find a recommendation within the existing constructs that we have to recommend use of this point-of-care HCV RNA test. And if you look back at our older algorithm, you'll see a very familiar pathway of antibody testing and, if positive, HCV RNA testing. But if you look, there's actually some footnotes to this algorithm that indicate for people who may have been exposed to HCV within the past 6 months, direct HCV RNA testing or viral first testing can be recommended in that setting, regardless of HCV antibody testing. And so with this in mind, we think that this point-of-care HCV RNA test would be well poised to be deployed in places with populations that have high risk for hepatitis C and high prevalence as well. So kind of putting it all together, we really want to move the field towards envisioning the same-day test and treat approach for hepatitis C. So the point-of-care HCV RNA test really opens that door quite a bit. But there's still some remaining barriers. A big one is the fact that there is no point-of-care hepatitis B test at the moment. Internationally, there exists a Hep B surface antigen point-of-care test that can be really helpful for ruling out hepatitis C and hepatitis B co-infection. And the FDA has signaled potential down classification from class 3 to class 2, which makes it a lot easier to bring these sort of diagnostics to market. So we're eagerly awaiting that. And then AASLD IDSA has been working as well on even further simplifying their simplified treatment, really to orient to the possibility of a same-day test and treat approach. And I think it's worth highlighting really the power of such an approach. So this is an example out of Australia. They did the PIVOT study, which was set in 4 Australian prisons. And the standard approach to hepatitis C screening and treatment, which is displayed in the figure on the left, is you go in, you get a reception interview, you get your antibody test. It's a different visit. You would get your RNA test. You go under further clinical assessment, need more testing, and eventually you get a DAA prescription. But overall, that took on average about 99 days from enrollment to treatment initiation. And ultimately, only about 22% of those who were diagnosed initiated treatment. By contrast, in their intervention arm, they developed a one-stop shop intervention that involved the point of care testing and as well as a fibroscan, and really cut that time from 99 days to 6 days, and rapidly or massively increased the proportion that were initiating treatment to 93%. So this is what we would love to see replicated into the US much more often. And there's a potential possibility to really have the resources necessary to do so. Perhaps some of you have heard that there is currently under consideration a national hepatitis C elimination initiative in the Senate that is sponsored by Senators Cassidy and Van Hollen from Louisiana and Maryland, respectively. And this would entail a large program that includes a lot of additional funding for testing and treatment, accelerating the development of point of care tests and other additional like injectable long-acting treatments, and as well as an infrastructure for supporting increased communication, awareness about hepatitis C, and technical assistance to improve implementation of test and treat models across the nation. So super exciting. We really won't know for a while until a CBO score comes back to know if this is something that will be eventually included, but we're very hopeful. But I think it's worth highlighting for this audience some ways that hepatitis B can piggyback on these potential developments. The first is one I've mentioned already is if we can bring a point of care Hep B surface antigen test to market, I think that would really help with increasing diagnosis of hepatitis B, which my colleague has demonstrated is woefully low. There's opportunities to piggyback on efforts to implement universal screening recommendations in health systems and other settings. Additionally, we can work to implement integrated testing in high impact settings, and the 4 that I had mentioned before. And there's opportunities to integrate vaccination with all the viral hepatitis screening where feasible throughout this process. And then lastly, this initiative would also entail an investment into our viral hepatitis surveillance writ large, which is underfunded relative to the disease burden that exists. So I remain very excited about this. For sure, a lot's going to happen in the remaining part of 2024, and it all just kind of helps me remember that elimination of viral hepatitis is achievable. We have all these tools. It's just a matter of figuring out how we scale their implementation. And that's all I have for you. Thanks.
Thank you, Dr. Furukawa, for that great talk. I'd like to bring all the speakers back for our Q&A session. And feel free to type in questions in the Q&A. We've already had one answered. Thank you, Dr. Kim, for doing that. But first, I want to say that we applaud all the leadership in viral hepatitis because we've seen expansions in both screening for hepatitis B and C and expansion of vaccination recommendations for hepatitis B. And we just learned today about a possible point of care test coming down the line for hepatitis C. So a lot of exciting developments. And even though we didn't cover it today, hepatitis D, as in dog, American Liver Foundation supports the elimination of all viral hepatitis. So with that, let's get to the questions. So let's start with hepatitis B. And Dr. Kim, very, very basic question. Patient asked, I've been diagnosed with hepatitis B. what are some of the tests that I need to be performed to know how it progresses and whether it's active or non-active? Dr. Kim.
Sure. Thank you for that question. So, first of all, the person who was recently diagnosed with hepatitis B virus infection should be linked to care for further counsel and management. So the providers can basically counsel on the risk and the treatment options if there are available. So in terms of blood tests that this person would need to get, that would depend on basically the treatment guidelines, which the CDC has not developed just yet. So I would recommend that this person can refer to the American Association for Liver Disease study of liver diseases for further information. But my basic understanding is that there would be tests such as liver function test, as well as the DNA test for hepatitis B virus, as well as other co-infections such as hepatitis C, as you've mentioned, and HIV. But the frequency of those testing would need to be dependent on the guidelines as highlighted in FAASLD.
Right. Thank you, Dr. Kim, for that answer. Let's move on to a related question to Dr. Wong. This, I think, is treatment related. So, Dr. Wong, just want to make sure this is clear. The question is, what does it mean to be positive for hepatitis B surface antigen and negative for HBV DNA PCR? Is that clear, Dr. Wong?
Yeah, great. Thanks so much for the question. So before I answer that, I think maybe take a step back and explain what do these hepatitis B markers mean. So I like to break it down that surface antigen is a marker of infection. Surface antibody is a marker of immunity. And then we think about core antibody as a marker of exposure. So someone that has persistence of surface antigen, by definition, has chronic hepatitis B. As Dr. Kim mentioned, once you have a diagnosis of hepatitis B, part of the workup is assessing disease severity, need for treatment, and that goes into measuring the viral load, hepatitis B DNA. So if you have surface antigen positive, you use liver tests as well as the hepatitis B DNA to guide need for treatment. If your hepatitis B DNA level is undetectable, that's really, so it's not just below the level of detection. If it says undetectable, that means that perhaps you're already on antiviral therapy. And that's, it's effective at suppressing the virus. But that doesn't mean you're clear. You still have hepatitis B. If you're on therapy, you still need to maintain suppression of the viral load, because if you stop therapy, you can flare and have a reemergence of the virus.
Thank you, Dr. Wong, for that very clear answer. We appreciate that. Let's shift now to hepatitis C, to Dr. Furukawa. First question from a patient: can a person, after being cured from hepatitis C, specifically the virus is currently undetected by PCR after treatment, can they still be infectious? I.e., can the virus still infect even if the virus cannot be detected by PCR? And I just want to say, with the HIV field, there's a new saying, or a relatively new saying, that U equals U. Yeah. Undetectable equals untransmissible. But Dr. Furukawa?
Yeah, thanks for that question. I think the answer just in general is yes. So if you've been either successfully treated and have an RNA test 12 weeks after you complete treatment and that is negative, or at some point you were infected and you, through spontaneous clearance, then get an undetectable RNA test, that is essentially indicating that you have been cured. There is a lower limit of detection that is around 30 to 15 to 30 million international units per international units per milliliter, but those scenarios of very low viremia are increasingly rare. And so I think it's very much analogous to the U equals U situation of undetectable equals untransmittable.
Thank you, Dr. Furukawa. One also related question is diagnosing hepatitis C and the markers. So could you please discuss the diagnosis of hepatitis C and why it's so exciting to have a point of care test possibly being FDA approved in the near future for use?
Of course, yeah. So the traditional algorithm that's been in use for decades has been to start with screening with an antibody test. And the antibody test will tell you if you have ever been exposed, but it cannot tell you if you're currently infected. So given it's a chronic condition, people who are antibody positive are then recommended to test for HCV RNA. And that RNA, the presence of virus will tell you whether or not you're acutely infected. But there's a lot of limitations with this approach. It is cost effective because most people will not have hepatitis C, and HCV antibody testing is less expensive than RNA. However, some notable challenges include the gap between some people getting an HCV antibody test that is positive, but not getting subsequent complete testing with an RNA. We've tried to bridge that gap by increasing the implementation of just automatic reflex testing. So if you've ordered this Hep C antibody test and it's positive, a lab will have already drawn an additional sample or draw from that same tube to do an RNA test. And another big gap is that for people who may have been recently exposed, there is a window period similar to HIV where you may be infected but are antibody negative. So particularly in high-risk populations, such as people who inject drugs, you may be missing infection in people who have been recently infected. So the ability to have a point-of-care HCV RNA test that can be deployed among higher-risk populations really helps kind of cut out that additional step of requiring an antibody test and allows you to, in that moment, assess whether one is infected. Now, it does take about 1 to 2 weeks for viremia from HCV to first be detected, but that's a much smaller window compared to the potentially 8 weeks or more for HCV antibody testing.
Thank you, Dr. Furukawa, for that great answer. Let's go back to Dr. Kim and hepatitis B. Two-part question. Can I still get hepatitis B even if I was vaccinated? And how long is the hepatitis B vaccine good for?
Those are really great questions, and thank you for those questions. So while breakthrough infections can happen, it is very uncommon in otherwise healthy adults, and it is possible that there might have been recognized exposure at some point before that person was vaccinated, and may even have been born to a Hep B positive mother and was infected at birth. And it is the very reason that we recommend triple panel screening for all adults, regardless of vaccination history. In terms of how long is the Hep B vaccine good for? For most people, revaccination is not recommended once they complete a vaccine series for Hep B. A study of members of Alaskan Native population published in 2022 estimated that 86% had effective protection 35 years following Hep B vaccination. Even those few with evidence of prior infection showed no evidence of active infection. With that being said, however, there are some instances where revaccination might be indicated, and those are specified in the 2018 ACIP recommendations. And the groups that are specified can include non-responder infants born to hepatitis B surface antigen positive mothers, healthcare providers, and people on hemodialysis based on their triple panel screening result if the surface antibody showed no immunity.
Okay, great. Thank you for that answer. Now to Dr. Wong. This is a question, not a lot of details, but just do the best that you can. My daughter has chronic HBV. How often does she need to have blood tests?
Yeah, good question. So it depends on a variety of factors, but at minimum, probably should be getting laboratory monitoring every 3 to 6 months. Generally, if you have more advanced disease, so for example, those that may have advanced fibrosis or cirrhosis, you probably should be getting monitored closely, like every 3 months. For those with very early stage disease or those that are on treatment, stable. Sometimes you can even extend it out to, once yearly. That's laboratory monitoring, and the laboratory monitoring is assessing your liver enzymes, your hepatitis B viral load. The other thing that's important to think about is risk of liver cancer. So liver cancer screening and hepatitis B is very important, but not all patients need to be screened. So if your daughter has cirrhosis, then absolutely yes. If you don't have cirrhosis, the current guidelines recommend for women starting screening at age 50 if you're from an Asian background and possibly African American. But most of the data is for Asian Pacific Islander ethnicity, and that justification is probably reflective of the route of administration, vertical transmission, longer duration of therapy, and hence the need to start screening for liver cancer.
Thank you, Dr. Wong, for that answer. So it's 4 o'clock, so I think we'll end the Q&A now, but please, Dr. Furukawa, there's one question in the Q&A remaining. And I just want to point out that both of these viruses that we discussed today cause liver cancer, and the American Liver Foundation has an upcoming webinar series addressing multiple aspects of liver cancer, and we encourage all of you to tune into those webinars that will be coming out from our organization. So thanks again with that, and I'll turn it over to Ivory for any last comments.
Thank you so much. I'll allow Dr. Nathan to answer that last question he wanted to answer live. I'll allow you to answer that question, and then we'll go to closing.
Okay, for those of you who have a little bit of extra time past the hour, I'll just briefly mention the question, which was what can be done to incentivize viral hepatitis care essentially within correctional settings. So I think when thinking about correctional settings in the US, it's very different than thinking about prisons versus jails. In prisons, there's a bit more of a constitutional and legal requirement to provide care for chronic life-threatening issues. And so on the prison side, they've actually had a decent amount of success through litigation to increasing the amount of funding available for hepatitis C testing and treatment of people who are incarcerated. Although much more work in that area to be done, especially kind of scaling up best practices, something that CDC is working on. The jail picture is a little bit more complicated in that jails are not really, they don't have a healthcare budget sufficient for themselves to be able to absorb the costs of testing and treatment. And a lot of the times don't just have the capacity or even technical know-how to do so. But with some of these developments, there's a lot of developments in place that may kind of open that door increasingly. The point of care HCV RNA test is a big one. But I think figuring out the payment piece is the bigger one. There are about 14 or so odd states, of which 3 have received Medicaid 1115 waivers. of the Medicaid inmate exclusion policy, which required either suspension or termination of Medicaid during the time people were incarcerated or detained. So places that specifically request a waiver of that inmate exclusion policy can have Medicaid coverage continuing. For people who are incarcerated, it restarts up to 90 days prior to reentry. For people who are just detained, it can continue throughout the duration of their detention. And that allows for reimbursable services and potentially the ability to do a lot of that testing and treatment in these settings. And then for kind of the pipe dream, the pie in the sky would be through a hepatitis C elimination initiative to receive the funding to make DAAs broadly available to people within correctional settings for free, such that it's primarily then focusing on ensuring that we're implementing appropriate universal opt-out screening on intake, and then providing the training for all the providers to be able to in turn identify and treat people with potentially a same-day test and treat algorithm. So there's a lot of promise in this space, but certainly a ton of work and troubleshooting left to do.
Thank you, Dr. Furukawa, and thank you, Ivory. I did see that we're going to go a little bit longer to 4:05 since we started a little bit late. So just one last question. American Liver Foundation is very dedicated to ending stigma that is associated with any of the viral hepatitis. But I specifically want to focus on one, which is being hepatitis B antibody or antigen positive. Dr. Furukawa, can you talk about some of the implications of possibly being infected by Hep B as a healthcare provider and some of the more recent updates that you've heard in the area to protect that population?
I might defer that question to either Drs. Kim or Wong as the B experts.
Sure. I mean, I can jump in and provide some context. I think, Dr. Thomas, that's a really important question. And stigma, especially with hepatitis B, is a really hot topic now because it's an important topic because it's contributing potentially to barriers to care. I mean, these patients are afraid to get care because they're stigmatized, they're categorized as high risk. We're identifying these people for previous recommendations. You screen them because they're high risk. You talk with them about these risk factors of transmission and this and that. So I think the fact that we're talking more about stigma and trying to use less stigmatizing language is important. There's a lot of data that still show that these people have concerns about work, family, talking about this, not just direct discrimination, but sort of indirect discrimination because of their known hepatitis B status. And that's why I think it's so important to really emphasize these new guidelines that we're screening everybody for hepatitis B. We're vaccinating everybody. And everybody that's identified needs to get plugged into treatment and sort of normalize screening for hepatitis B the same way we've normalized it for HIV and hepatitis C, sort of pan-viral screening for everybody, not because you're high risk. I will point out that Catherine Freeland at Hepatitis B Foundation has done a lot of work on stigma associated with hepatitis B and sort of the lived experience or the patient voice. So definitely for those that are interested, please check out some of her work that she's done in this area as well.
Thank you, Dr. Wong. Dr. Kim, anything to add to that?
No, I think Dr. Wong described everything really well. Just reiterating that in terms of screening and vaccination, we try to remove stigma and any barriers by implementing universal screening for all adults, as well as universal vaccination as for anybody who wants it and everyone who could get it.
Okay, thank you. And Dr. Furukawa, do you have your hand raised?
Yeah, I just wanted to add one more thing. I think in reviewing some of the questions in advance of the webinar, I did a little bit of a dive, and at least there were a few questions about people who were in healthcare professions themselves and had hepatitis B. And I just wanted to bring to people's attention that in 2020, the Department of Health and Human Services released a clarification that considered hepatitis B under protection of the Americans with Disability Act. And so that means that people can't receive just undue discrimination based on that status, such as being removed from a healthcare career pathway. So I think, it's a very difficult question of when to disclose, how to disclose, et cetera. Hepatitis B Foundation does have a lot of important resources that might help someone talk through kind of the pros and cons of that approach. But I think it's helpful to know that there is writ large a larger legal basis for protection.
Fantastic. And we did share some of that information in the chat. So please look in the chat if you're interested in learning more about the work that Hepatitis B Foundation is doing to fight discrimination for hepatitis B. Ivory, I'll turn it over to you again to wrap up.
Thank you so much, Dr. Thomas, and for doing a wonderful job moderating today. Thank you all to the speakers and to everyone who joined us. This was a great conversation. I think we can definitely continue this. Please reach out to the Liver Foundation with any more questions or comments or for more information, liverfoundation.org. We will also have this recording on our YouTube channel the end of next week, so you can go back and watch it. We will be sharing it with all registered participants in an email. Again, thank you all so much for joining us today. We greatly appreciate it.